It's my privilege to introduce the second speaker, who is Dr. Marie Bleakley from Seattle, US, and the title of her presentation is CD45 array T-cell depletion from peripheral blood stem cells for preventing chronic GVHD, results from clinical trials and laboratory studies. Please. And thank you for coming.
Thank you very much for the opportunity to present our research on selective depletion of naive T cells for the reduction of graft-versus-host disease. As you're aware, donor T cells contained in the hematopoietic stem cell graft have beneficial effects, including protection against pathogens in the recipient. But some donor T cells are also central to the pathogenesis of graft-versus-host disease. Depletion of T cells from the donor cell collection before infusion into the patients can be very effective in reducing GVHD. However, as you're aware, pan-T cell depletion is often associated with severe opportunistic infection, including sometimes life-threatening infection. So we became interested in developing a strategy of selective depletion of T cells with the three aims of preventing deleterious graft-versus-host disease, not necessarily all graft-versus-host disease, but the sort of GVHD that harms patients, including corticosteroid-dependent or resistant acute GVHD and chronic GVHD requiring systemic therapy. The second aim of selective T-cell depletion is to achieve adequate immune reconstitution to protect against infection. And thirdly, we want to preserve anti-cancer activity, both delivering a GVL effect in the graft and also making a transplant platform that is suitable for the introduction of post-transplant immunotherapy for high-risk patients. From previous research, it's now known that the naive T-cell depletion is enriched for T-cells specific for minor histocompatibility antigens, which are polymorphic peptides presented with HLA molecules on the surface of recipient cells. And they are the molecular target for alloreactive T-cells in HLA-matched transplantation. We also know from the work of Warren Schlomczyk and other groups that naive T cells in murine transplant models consistently cause severe graft-versus-host disease, much more so than central memory T cells and vastly more than effector memory T cells, which essentially don't cause graft-versus-host disease. So based on these data, we imagined a transplant strategy whereby we would administer donor stem cells and memory T cells without naive T cells, and evaluate whether that strategy could reduce GVHD compared to T cell replete transplantation and improve immune reconstitution compared to complete T cell depletion. So we looked at the potential to separate naive and memory T cells based on cell surface markers. As you know, CD45 is a surface protein tyrosine phosphatase, and the high molecular weight form of CD45RA is expressed on all naive T cells and only a subset of memory T cells. As shown in the flow plots on the lower left-hand graphs, we see multimer staining of antigen-specific T cells in red, and on the Y and X axes is CD45RA and RO respectively. And you can appreciate in the graph on the far left that the minor antigen-specific T cells, in this case SMCY, express RA, whereas the pathogen-specific, EBV-specific T cells shown in the right graph predominantly express RO, so removing RA should preserve your pathogen-specific T cells. So we obtained an NIH grant in those days and contracted Miltenyi Biotech to create a reagent with a CD45RA monoclonal antibody conjugated to an immunomagnetic bead to remove the CD45RA naive T cells from the graft. And you can see on the upper right-hand side flow plots that the reagent works very nicely to deplete the RA positive cells. We then developed a two-step cell selection strategy whereby we would positively select the CD34 cells, put them aside so that the stem cells were completely preserved. And then from the 34 negative fraction, we would deplete out the CD45RA positive cells to deliver a graft of 10 million total T cells with less than 75,000 naive T cells per kilogram. We performed preclinical studies and demonstrated that viral-specific T cells are retained in the CD45RA depleted graft, and also in that paper demonstrated that those cells are functional. We then went on to perform a series of 3 single-arm clinical trials, and these were published together in Journal of Clinical Oncology in 2022. And I'll just summarize that paper. So we evaluated a total of 145 patients in the 3 clinical trials. In the first trial we call 2222, we evaluated patients with HLA-matched related donors, used myeloablative TBI-containing conditioning to ensure engraftment, and tacrolimus monotherapy was given as GVHD prophylaxis. In the second trial, this was performed in pediatric patients, also patients with leukemia, and those patients also received intensive myeloablative conditioning, and this time in the context of mostly being unrelated donors, we added back some mini-dose methotrexate. The third trial was a large NIH-funded study of 80 patients, and we enrolled patients that had both matched related and matched unrelated donors, and as well as the intensive conditioning, we had an option for intermediate intensity conditioning. In that, and we used tacrolimus and mini-dose methotrexate and tacrolimus and MMF respectively for those 2 conditionings. In that third trial, there were 7 patients whose donors didn't provide sufficient cells for the cell selection, and they received unmodified grafts. This slide shows the patient and transplant characteristics of the 138 naive depleted transplant recipients. 52% had myeloid malignancies, 38% were at high risk of relapse based at either positive measurable residual disease at the time of transplant and or a history of prior relapses. 39% had matched unrelated donors, and 28% received the intermediate intensity conditioning. This slide shows the graft characteristics. We target a dose of 5 to 10 million CD34 per kilo with a minimum acceptable dose of 2 million per kilo, and this is universally successful. We target 10 million total T cells per kilo with less than 75,000 naive T cells per kilo, and have been able to achieve those targets in almost all the patients with a median of 2,500 naive T cells per kilo, so less than 1 log lower than the upper limit. And this has been successful in both match-related and matched unrelated donor recipients. When T cells are removed from stem cell grafts, there's obviously a concern of increased risk of graft rejection. However, we observed that the patients enrolled in these trials engrafted reliably and sustainably. They engrafted their neutrophils at a median of 15 days. Most developed full myeloid and full T cell chimerism. There was a minority of patients that had mixed T cell chimerism, and this tended to improve spontaneously. We did not need to give donor lymphocyte infusions, and we saw no association of mixed chimerism with adverse outcomes. A key question in these clinical trials was whether the selectively depleting naive T cells would reduce the rate of graft-versus-host disease. And what we saw was interesting. We found a very low rate of serious acute graft-versus-host disease, with only 4% grade 3 and no grade 4 acute graft-versus-host disease. We also saw an exceptionally low rate of any chronic graft-versus-host disease of 7%, including 1% moderate and no severe. Of note, we did see less serious acute graft-versus-host disease in the majority of patients. This was a stage 1 GI stomach GVHD in most of those patients, characterized by early satiety, some nausea and occasional vomiting, and this responded to prednisone in about 48 hours in most of the recipients, and sometimes just to topical steroids such as beclomethasone. You may challenge that as a success, but we actually do think that that was a positive in that we found that some GVHD in these recipients with hematologic malignancies protected them from relapse and was associated with a lower hazard ratio of relapse and of death. So this is evidence to suggest that a GVL effect is retained in naive T-cell depleted transplantation and is quite important. Coming back to the overall outcomes of naive T-cell depleted transplantation, we see the low incidences, relatively low incidences of relapse and non-relapse mortality. We see the excellent overall survival and very encouraging incidence of survival-free of severe acute or chronic GVHD. Moreover, the results of the HLA-matched related and matched unrelated donor transplant recipients were essentially identical. So the conclusions from the 3 single-arm studies were that naive T-cell depletion is feasible, is associated with exceptionally low rates and severity of chronic graft-versus-host disease, low rates of severe acute graft-versus-host disease, a shorter duration of pharmacologic immunosuppression than with T-replete transplantation, no evidence of an increased relapse rate, and opportunistic infections did not seem to be increased relative to historic T-replete transplantation. So this is great, but the obvious limitation of these data is it's single-arm, uncontrolled data. So we're now performing randomized control trials to evaluate naive T-cell depletion. We have 2 randomized trials going at the moment. The first is a pediatric transplantation and cell therapy consortium study being performed at 8 centers across the US as listed. We're enrolling children, adolescents and young adults with a history of acute leukemia or related malignancies who have HLA-matched donors. They're being randomized to naive depleted PBSC versus unmanipulated bone marrow transplant. There are 3 conditioning options, and the patients all received tacrolimus and mini-dose methotrexate. We've now randomized and treated 29 of the intended 50 patients and target completion at the end of next year. In the adult trial, we have 3 centers enrolling patients with leukemia and related conditions, again with HLA-matched donors. This time we're randomizing naive depleted PBSC versus PBSC with post-transplant cyclophosphamide as an emerging standard of care in transplantation. We're using TBI-based and busulfan-based conditioning options for lymphoid and myeloid malignancies, respectively, and giving tacrolimus and mini-methotrexate for the naive depleted recipients and tacrolimus and PTCy for the PTCy recipients. We've randomized 60 of our 120 intended patients. So I'm showing you a little preliminary data, exploratory data from this ongoing randomized trial of naive depleted PBSC and PBSC with PTCy. The first thing I want to note is that viral reactivation is infrequent in both arms, and most of what we see, almost all of it, occurs in the first 3 months post-transplant. So if you look at the graph on the upper right-hand side, the pale gray signifies no viral reactivation. The darker gray is viral reactivation on screening, asymptomatic with no no treatment given. The gold is low-level reactivation for which treatment was given and there was a rapid response. And the orange, treatment was given, and the red, an infection with end organ involvement. And you'll notice that the only grade 3 infection that we saw was in the PT-Cy arm, and so far there's been no deaths related to infection in either arm in the first 60 of the 120 patients. So that's very encouraging so far. I also want to point out that the lymphocyte reconstitution is encouraging in both arms of the randomized trial. If you look at this sort of right-hand middle set of graphs, we're showing the naive depleted recipients in teal, the PT-Cy recipients in lime green, and some T-replete controls in orange. And what we see is that the early post-transplant, the CD3 T cells tend to be a little higher in the PT-Cy group, whereas the NK cells are higher in the naive depleted group. The B cells are low in the first 1 month in both naive depletion and PT-Cy and recover by the second month. In terms of immunoglobulin, the immunoglobulin levels are adequate in both the naive depleted and PT-Cy patients, and they don't receive supplemental immunoglobulin at all. The IgA is interesting in that it trends higher in the naive depleted recipients throughout, and the IgM recovers earlier in the naive depleted recipients. We're also performing a more detailed analysis of lymphocytes in serial blood samples from the naive depleted recipients and some T-replete controls, and also in the unmanipulated naive depleted grafts. Specifically, we've profiled T cells, NK cells, and B cells in serial blood samples using multiparametric spectral flow cytometry. And we developed an unbiased metaclustering approach to evaluate approximately 20 markers for each of the subsets. I don't have time to go into in detail, but what we've observed so far is reduction, virtual elimination of the naive T cells, both CD4s and 8s in the early post-transplant period as expected. Also reduction of the TEMRA cells, again, because they express CD45, they're lower. But instead we see activated central memory and effector memory T cells, both 4s and 8s. We have ongoing exploratory analyses looking at the associations of these subsets with outcomes, and provisionally we've identified a population of CD4 cytolytic T cells that appears to associate quite strongly with the CMV serostatus of the stem cell donor, and also appears to associate with the GVHD that we observe in the naive depleted recipients. So to conclude, I want to thank you for your time and attention. I hope I've convinced you of the potential of naive T cell depletion to greatly reduce serious graft-versus-host disease while retaining protection against infections. I also wanted to draw your attention to the ongoing randomized control trials and the exploratory lab studies. I also want to thank my lab and to our collaborating labs and clinical research teams, to thank the various sources of funding, including Miltenyi, and many other people who have contributed, most importantly, the families and patients. Thank you very much.